and complications. She's a senior stoma therapist across KRST, who we work with on a weekly basis, almost daily basis. She's helping us out with our patients that do get stectomies and conduits. You can share your slides, sister. Thank you.
Morning, Dr. Sam. Thank you so much for allowing us to say something, especially when it comes to stoma therapy. Let me just see where I can share my slide. Okay. You can see that?
Yes, we can. Yes, that's perfect. Thank you.
Okay, so I'm Sister Jardine, one of the stoma therapy sisters at Grooteskeer. And I'm going to cover about 3 topics for stoma therapy. It's the counseling, the siting, and the complications. We, as the stoma therapy team, usually find the counseling very important when we deal with patients that need to undergo operations for stomas. And so preferably, we would like to see these patients 4 to 6 weeks in advance. And we would always like to see these patients in our clinics, or sometimes if it's in an area or surrounding, private surrounding or setup, usually because it will minimize the disturbance, and especially when the patient is so anxious that we have that connection with the patient. So it's always nice also to have the family member or somebody that's very close to that patient to be with them when we do this counselings. And because your patient is so anxious at the time that they usually forget the vital or important things about the stoma or about the operation that is planned for that patient. So we try and see if we can get somebody with that patient. And like I said, the counseling is usually very casual, informal, and that always makes it very easy, or that the patient is not so anxious when we do this counseling. There's a couple of topics that we would discuss with the patient and to get this collateral. So a lot of these is like your general information or social issues or social, like are they married, what are their hobbies, and that will tell us who's the patient and who we're dealing with. And when we also sit with these patients, we can already suss out to like their general health, their eyesight, hearings, their mental status, and dexterity, because all these little things that we look out for will eventually help us. Is this an indication, will this patient be able to manage their stomas at the end of the day? Will we need family or somebody, maybe even step downs or home-based carers to assist these patients with their stoma care? And usually with the counseling, when you talk to them, you find that are they fully aware of their diagnosis? Are they also aware that, say for instance, when they go for when they have bladder cancers, what's going to happen afterwards? Are they aware that they're even going to have a stoma at the end of the day, and what it is all about? So, and does the family also know what the operation or what the diagnosis is? This is a very sensitive topic, especially when it comes to men, when we talk to them about stomas, the sexual relationships, or females even so. And we need to know the current sexual activity. If they're going to have bladder operation, radical cystectomies, and have an ileal conduit, prior to even having the operations, what is the sexual activity? Is it normal, fair, or no? Because most of the time we find that these patients, at the end of the day, kind of blame the surgery that they can't, they don't have erection, or they've got poor sexual activities. So we need to know that way in advance. And what the sexual preferences is also with the type of patient we're dealing with. And of course, anxieties. When we sit with these patients now, it's so funny that sometimes they even, when they explain the operation to us, then they would say, they're going to take out my bladder, and the doctor's talking about maybe, or they talk about the gadget that's going to be put next to me on my side, or they would say, there's a pipe that's going to hang out, and then we know where we stand, or we kind of basically know how to work and manage explaining the kind of operation. So usually with your ileal conduits, we show them pictures and drawings of the gastrointestinal tract, and as well as the urinary system, and then explain to them that how they construct even doing the ileal conduit, because to see it with pictures makes it more clearer to these patients, and to explain to them in very simple terms what is actually going to happen makes it very easy. Now, we get called sometimes to cite patients or mark them. And for us, it's very important that counseling session. So with a stoma citing, that is just like a small part of it. But for us as stoma therapists, for the surgeon, and even for the patient in the long term, it is vital, if you have a stoma therapist, to do that citing if you have somebody around. And what we do with the citing is actually to let the person, there's three areas that we deal with, or like positions we put the patient into, and that is your lying position, sitting position, and your standing. And we look for, palpate for the rectus muscle. There are certain things that we're going to look out for. That is the, and then we will do our marking and our citing. So let me just take you through to the principles of how we cite or how we mark the patient. So we will mark within the rectus muscle. We will ask the patient then just to cough, and then we feel for that rectus muscle. The stoma site must be visible to this patient. If the patient can't see, I will show later on what we do, and also know the planned incision of the operation so that we don't mark in that area. And we usually mark the patient a left and a right on the abdomen, and that is just an option. And we mark the patient with a Koki pen. And usually we will cover that with a waterproof plaster or an opsite. And it's so funny that I went to see a patient, and in one of the disciplines, we were asked to see a patient, and I went to cite the patient, and the registrar, the surgeon, asked me, now, why do you cite the patient? And then we still even wipe this marks off. And I said, but then you need to score over our marks to show so that you can see where you're going to bring out that stoma. So when we do the sighting and the marking and it covers with the opsite, the surgeon then do their scoring on over that mark and then prep the patient's abdomen before they do this operation. So we basically went to do sightings for that discipline, and then they would just wipe it off. So areas to avoid when we do the sightings is we avoid the lower rib or the lower costal margin. And the planned incision, we also avoid. If there's obvious creases or old scars, we would also try and avoid that if it's possible. The eyelid crease, we also avoid because it's actually very difficult to pouch a patient when it's near to bony areas. And like I said, obvious creases. The waistline, because most of the time there's like a deep dip or sloot that we would call it, and that is also one of the things we avoid. The umbilicus, of course, because you can't pouch somebody that's in the middle of the abdomen. And there's special considerations that we would see if we can. I was going to see if I can move my face away somewhere. So obesity, when we deal with patients with lots of fat rolls, we look for the site that's, and we cite them on the apex of a fat roll. Your plan, say if for instance patients with abdominal that needs abdominal irradiation, we do a higher site for these patients. And then we have our patients, orthopedic and patients that with neurological conditions, like your patients that's in wheelchairs. So that patient, if we will ascertain if they spend like more than 50–80% of the time in their wheelchairs during the day, we will then make the patient sit in the wheelchair, and then we will do our markings or the sighting in that wheelchair. If the patient wear braces, belts and braces, so they will then be asked to put all these gadgets on, or the braces and the belts, and then we will mark the site that the patient will be able to see. The same with patients who has maybe scoliosis. So the most dominant side, or the side that the patient is able to see, that is the area that we will put the sighting on. So this is just a picture to show how we would mark our patients. So the picture you see on my left is a picture of a normal site. And then on my right is a picture where we mark the patient with a very big abdomen, belly. And if they can't see below the bellies, then we will do higher marks or higher sightings. And that was what we did for one, and especially that was a urology patient. I think when we talk about stoma complications is actually like a topic on itself. It can take up to our presentation, but I just try to minimize this, the stoma complications. And when the patient comes from theater, so your immediate post-op, that before 30 days, a patient that is not marked or sighted will give you most of the time even a poor sight or poor stoma, and that in itself will give complications. So immediately post-op as well, if the patient comes back from theater, is that stoma viable? Because then you have to look for necrosis or necrotic stomas. We look for pink, healthy, red, moist stomas, and we look for the Banderstens. Is there two, or it depends on if the patient still have both kidneys intact? Are we looking for the band stents, is it visible for us to see? And of course, is the flow of urine. Now, I've put in inappropriate pouching because when the patient comes from theatre, the patient would be preferably in a pouch that is that we can see through, or a transparent pouch, a two-piece pouch preferably, so that we can clip and unclip to see the viability of the stoma. And if it's not properly placed or even cut out properly, we deal with a complication. The same with a late complication as well. So if the patient is not was poorly sighted or even not sighted, then you may be sitting with a retracted stoma or stenostoma, or even a stoma that's in a crease or so. So prolapse stomas, that is your late complications, and your peristomal hernias, your skin, usually that is one of the most common ones where the patient have peristomal skin complication or peristomal skin complications, and also where it comes in with inappropriate pouching, because if they use, like I said, with a inappropriate pouching, even post-op, if they get issued with the wrong pouching, maybe in their communities, it can lead also to UTIs, because these pouches, the urostomy pouches usually has a non-return valve for urine to flow back into the stoma. I just took out some pictures just to show you what we deal with, and this is the common complications. Your necrotic stoma, and that is usually what we find that you immediate post-op. This patient here with a necrotic stoma on this side, that is actually a late complication. And so what you do with that, patient needs to go back to theatre for revision or a redo of that stoma. On this side, that is what, like say, your skin complications. It's normally very common, and contact dermatitis, that also depends on what the patient used to wash their stomas with, or are they allergic maybe to the adhesive, or is it urine that's seeping underneath? Was that stoma poorly mobilized, or is it maybe just the technique the patient uses as well? And then you see your prolapse stomas and how we deal with that. So you will most probably use a bigger pouch if we can. And if it doesn't give any issues to the patient, we would leave it. And your peristomal hernias, that is one of your late complications. And also, if we can accommodate and use a bigger pouch, or a pouch that will nicely mold over that hernia, we will continue to do that. And if not, if there's complications that maybe is for us difficult to see or to manage, we would then refer the patient to the different, maybe back to the surgeon, or if it's something to do with the skin, we will refer them to a dermatologist to assess the skin complication. So this is, I just thought, let me just bring in the types of pouching for the urostomate. And like I said, the two-piece pouch immediately, like post-op, and that is easy access to visualize that stoma as well. A stoma pouch with a tap, and like I said, with a non-return valve, so that the urine, there's no flow of urine going back into the conduit. And usually a pouch with a connection that especially post-op, that there's a flow right down that you can connect with a urinary catheter. And I think that's stoma therapy in a nutshell. That is one of our things that we do on a daily basis, seeing patients. Thank you.
Thank you so much, Sister Jardine, for an excellent overview of stomas. I see we've got a question there from Prof. Muchavira. Prof, you can go ahead.
No, I'd just like to thank Sister Claudine. I think most of the residents don't understand how important it is for us to interact like this, because it makes the complications you get from stomas are so massive. And I really just like to make sure that people understand this is not a Mickey Mouse thing. It's important. You have to make sure that you interact with people, because they actually make a huge difference to your outcomes for your patients. So thanks again, Sister Jardine.
Thank you so much.
Yeah, no, thanks a lot, Sister. Just maybe one last question for the time. And how different is it if you have to counsel a patient for an oral conduit? You know, I mean, we're talking about stomas, but versus for a neobladder. Because sometimes I think recently we will be sending you guys some neobladders. And how do you go about counseling one versus the other?
I think because we will counsel the patient usually for an ileal conduit, and then patient would also mention up to us a neobladder. And with the neobladders, we would explain to them, and it is vital when we do that, the session, asking them where they stay, is there ablutions, the toilet facilities, what kind of work they do, because if they, because you know, with your neobladder, you need to be that aseptic technique, you need to be sterile with dealing with your neobladder if they're going to have to empty out. And so that is important, the hygiene of the patient. Are they aware that they have to do that intermittent catheterization? And will it be, is it okay, or is it feasible, or how can I say it, that they will be able to do that on, like, your what does your daily activity allow you to do? So, and I think that is sometimes an obstacle for us, or even for the patient, because if we look at our patient load that we have, and the patients that the selector of patients we see, it's sometimes patient that comes out of rural townships, and that they don't have that facilities of a toilet and running tap water where they can do or have like a sterile setup, sorting, or do their intermittent catheterization. So yes, neobladders is an issue, and sometimes the patient, even though they opt for that neobladder, they then eventually, and I think the neobladders, if you what we experience, that your ileal conduits, they will leave earlier than your neobladders, and because it's easy, they discharge, and they would the neobladders sometimes stay even longer. But I think, and when they have the neobladders, that is actually when our side of our job then kind of stop, because we, like our other clinic, the urology clinic, that sisters deal then with the patient, explaining what to do, or even in the ward before they get discharged. With your ileal conduits or urostomy patients, we see them for a lifetime, and that is where our neobladders. But like I said, it is getting that collateral for the to see, can that patient actually have that neobladder, and is it going to work for that patient? If that patient's not able to do catheterization every 3 to 4 hours because of the type of work they do, or where they stay, or dexterity, then we don't know.
Yeah, no,
Thank
thanks so much, Sister, for an excellent talk again, great overview of the topic. I think you're quite right. You've mentioned the biggest issues, I think you're right, patients just opt to go for a code rate because it seems easier. And thanks for supporting our system. And I think Prof. Ramiro made a very big point there in that we need to just remember, and registrars need to remember to make sure they consult and collaborate with the stoma therapies, because we do all these procedures all the time.
Yeah.
Because bladder cancer is quite common. Thank you so much, Sister, for your time.
Thank you,
Thanks for
Dr.
the
Sam.
presentation.
You
All right,
too.
thanks. I'll see everyone next week.